My name is Faris, Alebdi, neurosurgery resident from King Fahad Medical City. I'll be presenting about the vascular management for tandem occlusion of anterior cerebral circulation, systematic analysis of 99 patients from the literature. We'll start with the definition. Tandem occlusion is defined as extracranial stenosis or occlusion of the carotid artery associated with thromboembolism to the distal intracranial portion, usually middle cerebral artery, anterior cerebral artery, or both. They represent about 8% of stroke patients. This is a CTA of a patient with tandem occlusion. As we can see here, there is severe stenosis at the cervical segment of the carotid artery and associated MCA obstruction or occlusion. This is a cerebral angiogram showing the same for the same patient. Why tandem occlusion? Although TBA is the standard of care in stroke management, only less than 1/3 of patients receiving TBA recover to a good clinical outcome. This poor response to the thrombolytics is attributed to the poor and limited delivery of the thrombolytics to the anterior cerebral circulation due to the proximal ICA stenosis or occlusion. New endovascular treatment of tandem occlusion have been developed showing promising results. Two approaches have been described, retro and anterograde, based on the sequence of addressing the two lesions. Starting with the anterograde approach is when the proximal ICA is revascularized using angioplasty and or stenting, followed by mechanical thrombectomy of the distal lesion. While in retrograde, it is quite the opposite, by addressing the symptomatic lesion first, by doing clinical thrombectomy of the distal lesion, followed by revascularization of the proximal lesion by angioplasty and or stenting. There are certain scaling system used in stroke patients upon presentation and after therapy. MRS stands for Modified Ranking Scale, measure disability or dependence in activity of day living stroke victims. The lower score is 0, highest is 6. 0 patient is asymptomatic, 6 patient is dead. So the lower the score, the better the outcome. NIHSS is National Institute of Health Stroke Scale, evaluate neurological outcome and degree of recovery in stroke patients. Again here, the lower the score, the better the outcome. TICI is thrombolysis and cerebral infarction, and geographic grading system determine the response of therapy in ischemic stroke. Here where 0 is there is 0, there is no perfusion, 3, there is complete perfusion. This is the cerebral angio of the same previous patient, and we can see stenting of the proximal ICA was done, followed by mechanical thrombectomy and re-establishment of flow of the left MCA. Methodology, we reviewed the literature using PubMed, studies that describe endovascular management for patients with tandem occlusion. We included patients who are 18-year-old or older at time of diagnosis, whom their data published in English in literature. Exclusion criteria include studies that did not describe most of the variable of interest, or studies that describe the variables and result, but were indiscriminate between patients. Review articles, published abstract, and conference presentation were also excluded. From the included patient, we reviewed demographic information presenting in IHSS, site of occlusion, endovascular technique and timing, use of antiplatelet and thrombolytic therapy, prognosis and complication. From our study, 9 studies were finally reviewed, 99 patients were included, median age was 64 years, male to female ratio 3:1. Median in IHSS at time of admission was 16, which means moderate to severe stroke with a standard deviation of 5.5. MCA was found to be the most common intracranial occlusion site associated with the ipsilateral extracranial carotid artery stenosis or occlusion. Mean time of onset of symptoms to recanalization 412 minutes. Mean time from groin to recanalization 83 minutes. Mean outcome modified ranking scale was 2.4 with standard deviation of 2. Overall, 6.2 of patients, 62% of patients had modified ranking scale less than or equal to 2 at 90 days. 81% of patients had modified ranking scale less than or equal to 2. Groin recanalization time was less than 90 minutes compared to only 50% with longer procedure time. 60.5% of patients received TBA had modified ranking scale less than or equal to 2, while only 52% of patients did not receive TBA had similar results, but it was statistically insignificant. Although only 7% of patients underwent retrograde approach, 85.7% of them had modified ranking scale of less than or equal to 2, compared to only 60% of patients with anterograde approach. Overall, 78% of patients had the ICI scale of more than or equal to 2B. 96% of patients who received TBA had the ICI scale of more than or equal to 2B, while 75.7% who did not receive TBA had the same TICI scale. The most common reported complication was cerebral hemorrhage in about 14% of patients. So in conclusion, tandem occlusion is a challenging condition to manage. Recently, endovascular treatment have been showing promising results. However, controversy is present around which technique to use. Good and favorable prognostic factors were found with a groin to recanalization time less than 90 minutes and using the retrograde approach. The use of IV TBA has been associated with higher TICI scale, and yet there is no superior prognosis in them. In our study, we advocate for the already done randomized clinical trials in stroke patients to do a subsequent analysis of the patient for only tandem occlusion, or to do randomized controlled trials for only tandem occlusion patients. Finally, I would like to take this opportunity to thank Dr. Abdulaziz Al-Sagga and Dr. Ibrahim Nami for giving me the chance to stand in front of you here today. Thank you.